Okay, we'll hopefully record this lecture so you can go back and re-listen to it as needed. For poisoning, prevention should be taught to parents. That's the most key things, because we want to, instead of treating poisoning, we want to prevent it. Your at-risk population are if the child is less than 6 years old, if the parents improperly store their meds, cleaners, if houseplants are on the floor, also lead-based paint, so your odor homes. This is a link to a forensic file episode where the little girl actually eats lead paint on a porch. It's like 30 minutes long, so I'll let you watch that on your own time. Lead poisoning depends, the symptoms are going to depend upon the level of exposure. If it's a low exposure, sometimes it's hard to detect. If it's high amounts of exposure, you could have cognitive delays, blindness, paralysis, coma, seizures, or even death. Since mild symptoms are hard to actually diagnose lead poisoning, there's routine screenings done at 1, 2, and 3 years of age. So we draw blood samples and we see what their lead levels are. Normal lead level, there is no safe amount of lead. Currently it's considered less than 5 is okay. By 2020, healthy people 2020 want it to be 1.4 or less. But currently it's less than 5. Treatment for lead poisoning is the chelation therapy using calcium, EDTA, and again routine levels are obtained at 1, 2, and 3 years of age. This is the poison control number, so with the education about prevention of poisoning, we want to make sure parents have this poison control phone number. Home management, so you want to tell parents when they call poison control, they're going to want to know who, what, when, how, the amount of medicine that was taken, what was swallowed, their weight, age, how long ago it occurred, route, estimation of how much poison received, and how the child presently is acting. So these are different, commonly accidental poisons. Aspirin. At the healthcare facility, they'll administer activated charcoal. The bad thing about charcoal is it tastes really bad. It's a fine black powder. They'll mix it with water, and they'll also add sweet syrup, so the child will actually take it. They could also do gastric lavage, sodium bicarb, O2 and ventilation if needed, vitamin K because of the bleeding tendencies with your aspirin, and sometimes hemodialysis. Tylenol, healthcare facility, they're going to give Mucomist orally. The problem with Tylenol is they can have a hepatic stage anywhere from 36 hours to 7 days, and it can cause death if not recognized and treated. Supplemental iron. It can cause death within 4 to 24 hours, so it's it can cause death in a short amount of time. They're going to do emesis or lavage, so chelation therapy using desferol. Prevention is key with all of these poisons. All of them, you want to remove the exposure to the poison. Once identified, provide care as needed. Think of your airway and ventilation first. Contact poison control. IV fluids, monitoring, vital signs, I&O. Administer the antidote. Gastric decontamination, and make sure you're keeping the family informed. Colic. So to define colic, it is severe crying for at least 3 hours, at least 3 times per week for 3 weeks. It can be caused by large amounts of food or air in the digestive system, but there is no actual known, of actually what causes colic. It's considered a feeding disorder. This infant will have abdominal pain. Treatment are distraction and or soothing techniques. Front carry sling, soothing music, pacifier, massage, warm bath. And this is just a short video of about colic. The parents get very stressed sometimes with the kiddos that have colic because they cry and the parents are lacking sleep. So you really want to pay attention to...
Well, colic is a general term that both parents and healthcare professionals use to talk about babies that have long crying episodes for really no apparent physical reason. There's lots of different definitions of it. One that's commonly used is crying that lasts in the baby for greater than 3 hours per day, greater than 3 days a week, and some people will say lasting longer than 3 weeks, but most of the time most parents are going to consult a healthcare professional before it gets to the 3-week point. There's a lot of theories, and there's not a whole lot of research to back up any one particular theory, but some of them include intolerance to milk protein, lactose intolerance, it's food sensitivity or an allergy to something in the mother's breast milk, something that the mother is eating. It could be caused from an immature gastrointestinal system. Could be caused by different feeding techniques. Some studies have shown that there's a possible increased incidence of colic with exposure to tobacco smoke. Another theory is that it's just some babies are hypersensitive. So there's a lot of different theories out there, and unfortunately there's no one good answer at this time. The onset is usually between 2 and 4 weeks of age, and then it can last up until about 3 months. They say about 60% of babies who have colic, it will disappear by 3 months, and then about 90% of babies who have colic, it will disappear by 4 months. And there's really no particular risk factors for colic, interestingly enough. It happens equally in male and female babies. It happens equally in breastfed and bottle-fed babies. It happens equally between full-term and preterm babies, and sibling order also does not make a difference. If you think your baby has colic or is going through long periods of crying and you're not sure what to do, make sure you do talk to your baby's healthcare provider. Another very important thing to do is that babies with colic, it can be very stressful on the parents. Having a newborn in and of itself is very stressful, even for a baby that doesn't have colic, but when a baby does have colic, it can be very high stress for the parents as well as the family unit. Make sure that you take a break from the baby if you need to. You want to make sure if you're ever feeling very frustrated and like you could hurt the baby, put the baby in a safe place, such as his or her crib, and walk away and call for help.
And it's a nice kind of lead into our current, or our next slide that goes over child abuse. Know that there's different types: physical, sexual, emotional, and neglect. This first video here is about 14 minutes long, so for battery purposes I'm not going to put it on this recording, but I highly recommend that you watch it. It's actually based out of Louisville, Kentucky, so it's statistics and stuff that are very close to home regarding child abuse. Child abuse is covered in your ATI book on page 500 to 504. You may suspect child abuse when history is incompatible with the findings, if parents delayed seeking care, if there's fractures in multiple stages of healing. People at higher risk of being abusers are young, single, socially isolated, low income, low education, low self-esteem, and substance abuse users. However, this does not say that people that do not have these characteristics are not going to abuse their children. Children are at higher risk if they're less than 1 year old because they require more attention, if they were unwanted, hyperactive, disabled, or premature. If the child has repeat visits and inappropriate responses, you may suspect it. If bruising is present on infants less than 6 months of age, you should be suspicious. So this is about the time that infants start to get mobile. And once they start moving around, bruises are a common finding. But before that point, you should suspect something's going on. Priority is to remove the child from the abusive situation, and also know that mandatory reporting is required if you suspect child abuse. Shaken baby syndrome is the most common cause of someone shaking a baby is because of crying, and we know babies do a lot of crying. It causes intracranial hemorrhage, bleeding behind the eyes. The specific injuries that are caused from shaken baby syndrome cannot be caused by something else. So it can't be when a kid falls or whatever story the parents are telling that's not matching the actual symptoms. Interesting statistic in Louisville, I forget, this has been several years back, but 100% of deaths reported by shaken baby syndrome, the parents refused the education that was offered at the hospital at the time of birth regarding shaken baby syndrome. So that's pretty astonishing. The most common perpetrator is a male non-blood relative, such as a mom's boyfriend. It's important we educate parents to, it's okay to take a break. So if they're overwhelmed, baby's crying, take a break. Walk away, take a few seconds to calm down, and leave the baby in a safe place. Also, be selective of the caregivers that you trust with your little ones. Again, I'll let you click on this YouTube link. It talks about, it's a short doctor's episode regarding shaken baby syndrome. Failure to thrive, we've defined it before as less than the 5th percentile on a growth chart. There's two different types. There's organic and non-organic. So non-organic, organic is caused from an underlying problem, such as a cardiac defect or GI disorder. Non-organic would be from neglect, poverty, beliefs, family stress. If you don't know the cause, remove the possible non-organic cause. So remove the child from the home, and if it still persists, then it's organic. If it gets better, then it's non-organic. So when the one thing I do like the Pearson textbook for is it kind of differentiates the difference in between adults and children. So pay close attention to those differences. With ears, the eustachian tubes of pediatric patients are shorter, wider, and more horizontal, so therefore they're more prone to ear problems and infections. One of them being acute otitis media, which is an infection of the structures of the middle ear. Otitis media with effusion is collection of fluid in the middle ear and no infection present. It's related to the malfunction of the eustachian tube. You may see frequent crying, irritable, fussy, inconsolable, tugging at the ear, pain, loss of appetite, nausea, vomiting. This is commonly seen in the first 24 months of age, and again at around 5 or 6, because they go to school, they get exposed to a lot of infections, they may see it again at that point. The first 24 months of life, they don't have their immunity built up yet. So acute otitis media, which is the infection, findings, they'll be lethargic. You'll see a bulging yellow or red tympanic membrane with decreased or no movement. Swollen lymph nodes, but that can also be a normal finding in children. Fever and drainage. The otitis media with effusion, they'll feel fullness in their ear. There will be an orange discoloration of the tympanic membrane. Hearing loss and also balance disturbances. Treatment's going to be pain control, usually Tylenol or Advil, or maybe even some medicated eardrops. Positioning, you want to make sure the child's positioned upright. And then antibiotics, if it's not resolved within the first 72 hours without antibiotics. So you always wait 72 hours. And then if it's reoccurring, they may place tubes in the child's ears. It's an outpatient procedure. It lasts about 15 minutes. Small incision in the membrane and tiny tubes are placed in the eardrum to equalize the pressure and minimize effusion. Mild pain afterwards. Tubes come out spontaneously in 6 to 12 months. You want to tell the client to limit their activities for a few days. Notify the provider when the tubes come out. Avoid getting water in the ears. Feed the child in an upright position. For drainage, they want to clean external ears with sterile cotton swabs. Avoid secondhand smoke and infections. keep immunizations up to date, report problems that the child may experience. Eyes. Pediatric patients, their visual acuity is different at birth. Instead of 20/20, infants' eyes are anywhere from 20 to 100 to 20 to 400. They can't accommodate well. By 2 to 3 years of age, it's 20/50, and by 6 to 7, they should be 20/20. Infants do not produce tears, and their cornea is very large. This here is a picture of conjunctivitis. It's an infection of the thin conjunctivi that covers the eye globe. This is on page 416 in your ATI book. It's spread by direct contact. It can be viral and bacterial. It kind of depends. If it's viral, it clears on its own in 7 to 14 days. If it's bacterial, it starts in one eye, spreads to the other, and clears with antibiotics. And if it's allergic, it clears with allergy meds. You can see a pink-red color in the whites of the eyes, swelling, tearing, pus from the eyes, and crusting of the eyelids. Skin, an infant's skin is much thinner and has little sub-Q fat compared to your older children and your adult patients. That's why they get cold so easily. This here is a picture of Lyme disease. It's from a tick-infected insect bite. If not treated, it can lead to cardiac, musculoskeletal, and neurological effects. If a client has been bitten by a tick for 30 days, you want to observe them for that 30, or in the last 30 days, you want to observe them. If certain criteria are met, they may be given an antibiotic. This is on page 8, in ATI on page 351. This is a picture of impetigo. Causes can be, it's a bacterial cause. Antibiotics are prescribed if it's a severe case. This itches pretty badly. Compresses of a beryl solution can be done to help remove the crust, and then use an antibiotic ointment. This is a fungal infection, referred to as candidiasis. This can also appear in the mucosa as thrush, which is very painful. Topical antifungal ointment, and if it's in the mouth, maybe something to kind of help with that discomfort so the client can still take liquids. Contact dermatitis is in your ATI on page 359. It's an inflammatory reaction. It itches. You want to wash it exposed to air and provide a skin barrier. Atopic dermatitis is an allergy, so it's not cured, but it's controlled. This is in ATI on page 362. Acne is in ATI on page 365 to 367. The big medicine Accutane that's given for acne, you want to monitor for signs of mood changes or suicidal ideation. That can be a side effect. Also, it's highly teratogenic, so it's contraindicated if the client becomes pregnant. So if you prescribe Accutane, or it's prescribed, you want to make sure they know that they need to be on birth control. Pediatric burns. Accidental versus inflicted. So inflicted would be a abuse case. Accidental obviously can happen with kiddos. You want to assess the depth, the degree, appearance, sensation, and healing. Extent injury for pediatrics, know that their total body surface area is going to be different. So when you learn about adult burns, it's the rule of nines, and with the children it's a little bit different. So their head's a little bit bigger, so instead of 9% they get 8%, 18%, and then their legs are a little bit shorter, so they get 13.5% per leg versus 18% of your adult. ATI, log on to ATI and click on your images under pediatric resources, and you can look at the images of the percentage of burns. For minor burns, you want to remove clothing and provide cool water soaks. Cover with a clean cloth to prevent contamination. Provide warmth to the child because they're going to be cold. Pain relief. No greasy lotions or butter. Monitor for signs of infection. This goes over your stages of your burns and how fast they heal. There's a nice chart on page 373 in ATI. ATI also has a nice image of the stages of burns that you can look at. Major burns, airway is your priority. Ventilation, provide oxygen, monitor vital signs. Maintain cardiac output. Urine output. Blood products if needed. Monitor for septic shock. Pain, infection, nutritional support. Wound care can be very extensive and long process for these patients, painful. This is a nice little video about burns. I'll let you watch it. It's about 7 minutes long. You can click on the link through your PowerPoint. For your immune system, infant and children have different amounts of immunoglobulins. IgG crosses the placenta, so newborn levels equal that of the mother for the first 6 to 8 months of life. Then they start to decrease, and mature levels are not obtained until 7 to 8 years of age. IgM is low at birth, and adult levels are reached by 1 year of age. IgA and IgE, they're not present at birth. Production begins about 2 weeks, and normal values are obtained by 6 to 7 years of age. HIV, so we talked about it in pregnancy and in utero, and when you talk about it in pediatrics, know that the most common cause of pediatric HIV infection is transmission from mother to fetus. That's a big one. For adolescents, if they become HIV infected, it's from unprotected sex, and then there's a higher incidence coming about from drug use also.